Good afternoon, class, or I guess I could say evening. I did my case study on case study number 32, which was dialysis and renal transplantation. My patient is a 60-year-old white male who presented to the outpatient dialysis center for a staff-assisted hemodialysis, which he was diagnosed with 4.5 years ago, with also being diagnosed with polynephritis resulting in renal failure. His past medical history, he had his usual childhood diseases, the measles and the chickenpox. He was diagnosed 35 years ago with having nervous colitis. He also had 4.5 years ago was diagnosed with new onsets of lactose intolerance and irritable bowel syndrome, also diabetes mellitus type 2, and the usual reoccurring cold. Surgical histories, he had his tonsils and adenoids removed when he was 5. He had a left inguinal hernia repaired at the age of 7, and then had the right one inguinal hernia repaired at the age of 26. A fractured forearm at the elbow at the age of 40. Had kidney stones removed 4.5 years ago, and also had a chest catheter surgically placed for his hemodialysis 18 months, 27 months, and 41 months ago. My patient, is taking pioglitazone for his type 2 diabetes. He's also taken levofloxacin, which is an antibiotic, after dialysis treatment to help fight off any infections that may occur during his treatment or after his treatment, following his treatment. He also takes calcium acetate after dialysis, and that's taken after his dialysis treatment because if it was given before, it would be dialysized out of his system, which would be defeating the purpose of giving him the medication in the first place. He also takes quinine sulfate before dialysis, and that helps with any muscle spasms that he may endure during his treatment because of the potassium levels. My patient is in late end stages of renal failure, and you can tell this by his clinical presentation of the scaly skin. He's got mild edema bilaterally in both foot and ankle, which is a +2, and his strength is very weak in his upper and lower, more so in his lower extremities than his upper extremities. He's requiring the hemodialysis because of the kidney failure. His hematocrit is at 30.7%. He's losing the fluid somewhere because the normal levels is 39 to 49%. His HB hemoglobin is 9.5, which is very low, considering the normal is 13.6 to 17.5. With the exception of his hemoglobin and hematocrit, all his lab values came back with the normal range, except for the potassium, which was increased, his HCO3, which was low, his BUN, which has increased, his creatinine had increased, and his PTH had a tremendous increase, which was 1835. That's 1,835 when the normal range is 11 to 54. So he did have a tremendous increase there. I had some people ask me what osmosis, diffusion, and ultrafiltration was. Well, osmosis is the physical separation of particles moving across the semipermeable membrane from a solution of higher concentration to a solution of lower concentration, resulting in even distribution of the particles. Little energy required. Very simple. Now, diffusion is when, let me see if I can describe this to you, characterized by movement of pure solvents through selectively permeable membranes from a solution that has a lower concentration to one that is a higher concentration, crossing paths. Ultrafiltration is the physical separation where the process carried by moving a fluid from region from higher to lower. So this patient takes multiple drugs since his transplantation due to you don't want the rejection of the new kidney to take place. So the more medications you take, the more or more antibiotics that you can take will help with different infections and viruses that you may endure. The dialysate solution was higher glucose concentrations increases the osmosis, causing fluid to remove from the blood, which is it's true. It's a true statement. Weight gain. Woo! Nobody likes to gain weight. Weight gain from post-transplant cortisone use is primarily a result of fluid retention. No way around it. So they may be put on a different medication to help with the reactions of the steroid, possibly a diuretic or something. The corticosteroids induce diabetes and kidney transplants? Yes, because you're unable to remove the waste from your body quickly like a normal person would, so you have that in the back of the mind. Most of the patients have complaints, especially with inflammation of the pericardium around the heart, because the most of the complications is infections, which occur by the catheter site as it so that would be their number one. And the most common type of infection is the peritonitis, which is 0.8 episodes per patient per year, so it's very, very rare. Hyperkalemia is another concern because of the complications of kidney failure, and that's because of the high serums of potassium concentrated in the person's system. Metabolic acidosis complications of kidney failure? Yes, because there's severe metabolic acidosis with the plasma of a pH of 7.20. So that does raise a concern with patients.